Okay, there we go. So yeah, my name's Nick Anderson from Salt Lake City. A little bit of background before we go into this, and as was previously stated by Dan, we're going to go about 100 miles an hour through this. So originally from Salt Lake City, went to graduate school back east, moved back to Utah, took a position with Intermountain Healthcare, not realizing that within a few months I was going to be called a payer. I didn't know what a payer was. I'd never heard of a payer. I'd spent the last 10 years in a laboratory. And with as powerful and influential as Intermountain Healthcare is, there literally was me and the medical director who determined what was going to be bought and paid for by Intermountain Healthcare. You would think there would be a team of 20 health economists and medical technology people and regulatory attorneys and things. There wasn't. My apologies to probably half of you who I denied your products between 2010 and 2017. I'm no longer with Intermountain, but within 6 months of starting that job, I was really blown away by, you've got to give me, you got to be kidding me that such and such medical device company raised $40 million, and I know they did because I went to their website. They got a patent, they got a whole team of smart people to quit their jobs and come work for them. Then they got FDA approval. They sent a sales guy to Salt Lake City who got such and such urologist to sign up to use their product. The urologist implanted the device in one of our patients. Well, we wouldn't call him a patient, we'd call him a member. They put the device in one of my members, and the bill comes to me and I go, what the heck is this? No, I'm not paying for this. Like, how in the hell did you get from, hey, I have a cool idea, to I'm gonna sell this in Salt Lake City, because we've done all these champagne cork popping moments over the last 10 years of R&D and product development. And then 30-year-old Nick Anderson sitting in a desk in Murray, Utah goes, no, Intermountain Healthcare is not gonna pay for this. So how did you check all those boxes only to have one snot-nosed kid in Salt Lake City destroy it for one of the most influential payer integrated delivery network systems in the US? So something was wrong. So I went to the medical director, he's an internist, and I said, Ken, do you mind if I do some consulting? Because I want to go tell these companies how I look at this as a payer. And he said, yeah, sign the conflict of interest disclosure. I did, and then I did consulting on the side from that full-time job for the last eight or 9 years now. Running around the country, running around the world. I got to go to Dubai last year and lecture on health economics and outcomes research from a payer's perspective. How do payers look at medical innovation, and what do we want before we pay? Skip to 2015, I get a phone call from my neighbor that says, come meet my brother-in-law. He's got a new skin technology. And I kind of rolled my eyes because I've evaluated 1 million bioengineered skin substitutes, and I was like, oh great, this guy's got another one. Went over to my friend's house, met his brother-in-law, and I said, well, that's great. How does your technology compare to this one and this one and this one? And he said, Nick, you don't understand. I can literally grow back full thickness, autologous, homologous skin. And I was like, can't we all? So like, I've heard this. And he goes, no. I go, so how do you compare against this product and this product? And he goes, no, you don't understand. I can literally grow back skin. And I'm like, okay, you've got my attention. And I had just got done writing the clinical dossier for a client as a consultant on a bioengineered skin substitute. So he gives me a call. I didn't hear from him for about a year after that. We went to raise some money. I got a text from him in January of 2017 that said, hey, can we go to dinner? Between December of 2016, the company was founded. I work for a new company called Polarity TE, but I'm presenting today on behalf of my own consulting thing, NC Anderson Consulting. But let me go back. December of 2016, Polarity TE was founded. We were publicly traded in NASDAQ in March, FDA registered in August, and we were on patients in Thanksgiving with a biotech company, and we're literally growing back hair-bearing full-thickness skin for burn patients and diabetic wounds and so on. that amazing? In 1 year? Well, thank you. So in 1 year, a biotech company went from, I have an idea, to I'm on patients in 1 year in a regenerative medicine company. So I was very happy to hear you, Michael, talk about, this, like, let's get going, let's move, there's no reason why this stuff has to take 7 years. I've read the book of Genesis. On the 8th day, God did not create the biotech commercialization timeline that necessitates like 8 years of art. No, you can do this quicker if you hurry and hire a lot of people. We just bought a 200,000 square foot building last month. So we're manufacturing. This is on patients right now. So I'm going to talk, this talk is a 3-hour lecture that I give at UCSF every year that I'm crunching into a half hour. So wish me luck. The first half, we're going to talk about health economics and outcomes research. And the last half, I wax a little more philosophical on where I think medical technology is going, given the fact I've worked with, I don't know how many biotech companies and how many student groups, the Stanford Biodesign Group, and some of those that I mentor some of these students. So let's kind of jump into this. And this is gonna be the most obnoxious 40 minutes of your entire life. You'll learn to love me. I'm an acquired taste. So health technology assessment, it's essentially an assessment of safety and efficacy. Now again, I'm gonna talk to you as though this was a year ago when I was still a payer. We will assess drugs, for example. Should we, as a health plan, Aetna, Cigna, Blue Cross, Medicare, whoever we are, should we be paying for ketamine for the treatment of depression or pain? Is there adequate evidence that I should be, let's say all of you are on Cigna, all of you have Cigna health insurance. Now, let's pretend all of you are stay-at-home moms, school teachers, doctors, engineers, average Americans, right? Should I, as the payer, I'm the one who all of you give $1,000 a month to on behalf of your monthly premium, or your employer does. I've only got this much money, $1,000, $2,000, $3,000, $4,000, $5,000, $6,000, that much money to pay for your heart transplant, your diabetic foot ulcer, your runny nose. So I have to judiciously spend that money. That money comes to me, and then a physician shows up and says, Nick, I've read some really good information on ketamine for the treatment of major depressive disorder. It's an infusion, a chronic infusion. You go into the doctor's office, they stick a needle in your arm and drip ketamine into you to cure your chronic pain or your depression. And so I have to take a step back and go, okay, is that something I should be taking all of your hard-earned money to pay for? Is there adequate evidence that the improvement for the number of patients that have major depressive disorder or chronic pain, we reviewed it for the 2 separate indications, should I write a health technology assessment on those 2 indications? So then we determine as a team of, again, 2 people that, yeah, this is probably something we should look at. Major depressive disorder is a big deal in the state of Utah. Remember, I work for Intermountain Healthcare, regional payer. Yeah, this is probably something we should look at. There might be actually really good evidence that this works. So then I spend the next 6 weeks, is about how long my timeline was, to do all the data gathering I could around those 2 indications for ketamine use. And then I write up a health technology assessment that might be 20 pages long. We present that to a committee of physicians and nurses, and the committee says, yeah, this looks like a reasonable intervention per the cost and da-da-da-da-da. All in favor? Yes, we should be paying for it. Then it goes to a committee that I chair called the MTech Operations Committee. By the way, this isn't just Intermountain that does this. Every payer has some health technology assessment type committee that's going to be reviewing your technologies. And then I chaired that separate committee, and that committee might be like, Nick, that's great you want to pay for this, but we can't. Because your health technology assessment says that this only works in women over the age of 50 that are blah, 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 blah. We can't write an edit in the system to deny coverage for men under the age of whatever. So despite the fact you did a great health technology assessment, we can't implement that in our system. There's no way to make what's called an edit at the health insurance company to only pay for women over this age and not pay for men under this age and so on and so forth. So, by the way, these do work. ketamine treats lots of things, says every college student ever. It's cured a lot of depression in college students for 30 years. But yeah, the evidence was that you had a 0.5 milligram per kilogram per hour of chronic infusion, and you got 1 day of relief for every 1 hour of infusion for major depressive disorder. So you'd think, okay, I go in for an 8-hour infusion. Well, yeah, that gives you 8 days of relief from your major depressive disorder. I don't know how many of you, again, single moms, school teachers, can take 1 day off every 8 days to go have an infusion of ketamine. So it was impractical, it didn't make any sense, it was a ton of money, even though ketamine's cheap. It was off-label, but we didn't care about that. We're payers, we're not the FDA. So that didn't matter to us. We were looking at, if it works, we'll pay for it. Devices, robotic pancreatectomy. I actually wrote the review on robotic pancreaticoduodenectomy. Long story short, it took me 3 months to figure out that this was an incredibly expensive way to do what open or laparoscopic pancreaticoduodenectomy can do. Instead, you're using a robot that costs a ton of money, and it doesn't improve any outcomes at all. AxiaLIF is a lumbar fusion to fuse L5S1, if I remember correctly. I had to review it twice. I reviewed it in 2010 and we denied it. There wasn't enough long-term data for a major orthopedic device. We decided to not pay for it in 2010. An orthopedic or neurosurgeon, I can't remember, said, guys, I really think you should look at this again. You should be paying for AxiaLIF. This is a great technology. So we reviewed it again in 2012 and denied it. And then we reviewed it again in 2014 and covered it. So if you get denied by a payer, it might be a lack of evidence or a lack of health economic data, but that's not the end of it. You might have to do it 2 or 3 or 4 times over the course of a few years. Hopefully you do it right the first time and you have a nice compendium of prospective data, health economic reports, and so on, illustrating the safety and efficacy of AxiaLIF. UroLift, well, we can skip that, I just don't have time. Propel was an interesting one. I don't know how many of you know Propel. It's a stent, a bioabsorbable stent that goes up in your nose after functional endoscopic sinus surgery. So normally they go up, roto-rooter out your nose, and then you grow these polyps inside your nose. Well, Propel has dexamethasone, I think. I can't remember what it's impregnated with. But it's a bioabsorbable stent that goes up your nose, and then over a course of weeks, your body absorbs it as it elutes this drug into your nasal cavity. So when I talked with the company, I said, what's your guys' real claim? Like, what are you trying to do here? And they said, well, by eluting this drug, you don't have these polyps that grow. And then you, the payer, you're going to save a lot of money, Nick, because then you don't have to pay for the polypectomies. So I said, all right, let's see how that works. I went to the next door building, went to the 3rd floor, to the actuary department, walked down the hall to Julene Wadsworth, an actuarial fellow that I worked with. And I said, Julene, I want you to pull for me right now these CPT codes, all CPT codes for functional endoscopic sinus surgery, FES. So she pulls it and says, okay, we had, whatever it was, 10,000 people last year that we paid for a FES. And I said, okay, in the perioperative period, let's go out 8 weeks per the data, per the published literature. How many of those 10,000 people had a polypectomy? And she said 0. So do people get polyps after FES? Yes. Do physicians bill for the polypectomy? No. So you just solved a problem and you took $10 million, $50 million from investors to solve a legitimate biotech problem, or a medical problem, but one that physicians were going, look, after I do your FES, I shove gauze up in your head on Monday, you come back 2 weeks later, I pull the gauze out, or whatever the treatment standard of care is, and yeah, you have some polyps, I snip them out. That's part of the surgery, you know. The polyps don't grow for a few weeks, and I'm not going to bill your insurance company for it. It takes 2 minutes. So real problem, yes. Real solution, yes. Elegant solution, furthermore, but just not a problem that we needed to pay an extra $900 for. Pharmacogenomics for psychiatric medications. I can sum this one up really quickly. I have to pay $2,200 for a pharmacogenomic test to tell you that you shouldn't be on an $8 drug. JC virus, John Cunningham, not Jakob Creutzfeldt. John Cunningham virus for progressive multifocal leukoencephalopathy with natalizumab. If you're on natalizumab for multiple sclerosis, and if you have JC virus, which 50% of the population has, but your immune system keeps it in check, when you get on natalizumab, it's an immunosuppressant. JC virus takes off and starts to give you the same symptoms you have with MS. So all of our neurologists said, guys, this JC virus test is super inexpensive, and right now it's a crapshoot. Half of you I'm going to give natalizumab to, and you have JC virus, and you're going to have these symptoms. The other half you're not. Would you guys mind paying for this? I went and did some research. Super inexpensive test. It works very well, and that was something we ended up covering. I'm going to skip to chemosensitivity. Chemosensitivity testing for cancer. So the theory is you get, let's say, a liver mass, and your surgeon looks at you or your oncologist and says, all right, Nick, you're a 36-year-old Norwegian-American male. I think you should have these 5 chemotherapies to treat your liver mass. But if I only knew what your genes were, then maybe I would only give you these 3. Maybe these 2 don't work for you. Maybe you would hypermetabolize them or hypometabolize them or whatever. Maybe they'd be toxic to you somehow. So wouldn't it make sense if I could do a genetic test on each one of you who have liver masses or pancreatic or brain or whatever to find out exactly what combination of drugs you should be getting? And makes a lot of sense. I mean, this is personalized medicine, N of 1, best of the future of healthcare. Well, this company called me as a consultant and said, Nick, we would like to do this, and would you review our clinical trial protocol for our animal model? And I said, sure. So they sent me their trial, and I went and pulled all this data from Aetna, Cigna, Blue Cross about chemosensitivity testing for cancer treatments. And every payer said, though evidence of analytical validity and clinical validity have been clearly established in chemosensitivity testing, no one to date has illustrated the clinical utility of such tests. Okay, if you don't remember anything that I talk about today, please memorize analytical validity, clinical utility. Analytical validity is the baseline nerdy scientific stuff that biostatistician type people do. Analytical validity is like the baseline you would have to go raise any money from an investor. The second is clinical validity. Clinical validity is a kind of a step up. Once you have that, now you really have a product. You kind of have something you can sink your teeth into. The top layer is clinical utility. Clinical validity, clinical utility. So, all right, what if Nick Anderson did have a liver mass, and what if I did get those 5 chemotherapies, but I only needed these 3? So this company was arguing, Nick, we need to do another animal study to show the analytical or clinical validity of our test to show that this actually makes an improvement. And I argued back to him and I said, first of all, these are animals, not humans. So clinical utility still hasn't been answered. And furthermore, what difference would it make if Nick got these 2? Would I vomit one more time, or would I have neutropenia? Would I have an emergency room visit, or would I just have a bad afternoon? So me as a payer, if I have to pay for your chemosensitive, what they were going to do, by the way, is harvest a chunk of your tissue, of your tumor, send it to their lab, they chop it up, put it in 5 mice, let it grow, kill those mice, put it in 20 mice, kill those, put them in 50 mice, and then try different cocktails of chemotherapies on those 20 or 50 mice and say, oh, it was mouse number 36 that responded best. Nick's oncologist, you're going to want to use these 3 chemos on him. Don't use all 5, because mouse number 36 that had his tumor in it responded best to these 3. Well, what happened to the mouse that got all 5? It threw up one more time? You know, so mice don't throw up, by the way. But you know, you would have had one, if the mouse could, it vomited one last time. Do you have any idea how expensive that test is to keep a cancer patient from vomiting one more time? Now, if they could actually do the real clinical trial like all the payers said nobody has done, well, now they might actually show, no, it's not just vomiting, it's actual trips to the emergency room on your deathbed because your white blood cell count has been completely eradicated. So we could talk about that one for hours, but I better get going. Heart transplantation after the age of 70. My medical director came to me and said, Nick, 65's been the standard of care since I finished residency in 1981. There's no way that we can't do heart transplants in patients over the age of 65. So I went and did the research and said, yeah, it actually looks like there's really good evidence for us to start paying for men and women to have heart transplantation after the age of 70. And we changed our payment guideline. Third eye retroscope, Cologuard, we'll skip some of that. If you also can take one more thing away from this, learn everything you can about number needed to treat. It's kind of health economics in one simple, nice, round number. You know, we could do an entire health economic course at a university, and it would take a whole semester. But if you can learn everything you can about number needed to treat, how many people, you know, we could also talk about quality adjusted life years, ICERs, Kaplan-Meier, levels of evidence, et cetera. But in short, how many people need to be treated with the device or diagnostic to help one person avoid the thinger that the intervention was designed to avoid? So how many people do I have to put Propel in their nose to help avoid a polyp growing that had I not used Propel, they would have had the polyp? Is it 5? Number needed to treat is normally 1 divided by the absolute risk reduction. So if you know that shoving gauze up somebody's head, 1 out of 10 patients is going to get a polyp, but with Propel, it's only 1 out of 3. 1 divided by absolute risk reduction is your number needed to treat. It's an easy number you can go sit in front of a payer, and then what a payer can do is say, okay, your number needed to treat is 5. So how much is your device? And you say it's $1,000. And you go, okay, so I'm paying $5,000 to help avoid that 1 additional patient that had I not used your device, they would have had the thing that you're trying to avoid. Well, if that thing you're trying to avoid is $5,001, well, then you have something. You're saving $1 for the healthcare system. If it's $4,999, you're just adding cost. It'd be cheaper for me to pay the $4,999 than it would be to pay the $5,000. Because remember, I'm paying 1,000 for your number needed to treat of 5. So, heart transplant. How many patients would I have to put your device in to help somebody avoid the thing that I'm trying to, you know, a stroke or whatever it may be? Really easy number to wrap your head around. And there's a great website called thennt.org or .com or something. It's some real nerds that have built a cool website only about number needed to treat. NeMD is my wife's cousin's medical device. He builds ski boots and ski bindings for a living for Black Diamond and has arthrofibrosis in his knee. He's had, how many, Holly? 8 surgeries or something? 8 total knee surgeries because he keeps growing all this scar tissue in his knee. So he came to me and said, Nick, I just invented this device. You just wrap it around your leg and pull it to pull your leg straight. And I don't know how much I can charge for this. I know medical devices are crazy. Should I charge $1,000 or $50,000 for this? And I said, well, let's figure it out. Let's do the health economics to do evidence-based pricing. We always talk about evidence-based medicine. Do we talk about evidence-based pricing? Very important concept. Does your price match up with the outcomes gained? I don't need to do that when I buy a new suit. I don't need to do that when I buy a new clicker. But you do that in medicine. And Medicare and Medicaid is really clamping down on this stuff lately, saying, prove to me how you came up with your price. Show me, would you please, how you came up with $900 for your new stent or your new whatever. Don't just pick a number based off a market cap that is a return on investment for your investors. That's not going to cut it with Medicare anymore. So I said, all right, let's figure out. So 12% revision rate after a total knee replacement, and 14.6% of those revisions, so 14.6% of the 12%, are because of arthrofibrosis. So 1 divided by 0.12 times 0.146 is 57 or something like that. I can't remember off the top of my head. So in short, very crappy, quick number needed to treat analysis, but I said, Jake, roughly we're talking about 1 in 57 people are going to have a knee replacement because of arthrofibrosis. So I'm going to have to give NeMD to 4 times 1, 2, 3, 4, 5, 6. All of you are going to get NeMD after your total knee replacement to help one of you from here over avoid a total knee replacement because of arthrofibrosis. So how much is a knee replacement? How much is a revision surgery? 40 grand? Okay, so what's 40,000 divided by 57? That's how much we can charge for KneeMD, $230. See, I can't charge, if I charged $1,000 because that's what my investors want, I'd be charging $57,000 to help avoid spending $20,000 for one revision surgery. So what you do is take the number needed to treat, take the cost of the revision and divide that by the number needed to treat and minus $1, so you leave something on the table, and that could be your health economic claim. I won't get into Cologuard too much. You've seen Cologuard, the box in your bathroom that talks to you. So I won't get in that left column. Those numbers aren't correct, but I'm not allowed to disclose what Intermountain charges for these things. This box right here is from that paper, PubMed ID 897 the sensitivity of Cologuard and the sensitivity of fecal immunochemical testing. And then this is probably from that paper, I can't remember. 95% roughly sensitivity for a diagnostic test for a colonoscopy. Those numbers, this is really interesting. Cologuard is only 17% specific for a non-advanced adenoma. Remember, everybody, I'm doing this as a payer. I'm sitting in a health insurance company doing this. This is going to determine whether or not Cologuard gets into Intermountain Healthcare. So, versus this, well, yeah, that's better than that, but it's not as good as this. So how is my stupid human brain supposed to make any sense of this? The sensitivity and specificity and positive and negative predictive values of those numbers for Cologuard, fecal immunochemical testing, and so on. Well, what I was able to do is to take sensitivities, 1 divided by sensitivity times incidence is number needed to treat for a diagnostic test. 1 divided by incidence times sensitivity is my number needed to treat. So that's what I did over here, and I multiplied it by these costs. So colonoscopy is about that much money, FIT is about that much money, and Cologuard is about that much money. So I could take those and put them over here and go, okay, now this is helping me make sense of really how good of a technology this is. The number needed to diagnose, 21.7 for colorectal cancer, 27.1 for FIT, so it's a little bit better, 6, 7 people, better, versus colonoscopy. This one, 21.1 and 21.7 look about the same to me. You always have to round up a number needed to treat, so they're both 22. So now look at the cost. For Cologuard, I would only have to spend 13 grand to find one more colorectal cancer, but I'd have to spend 29 grand if I did colonoscopy. Okay now? So it sounds like a pretty good case for Cologuard if you ask me. As a payer, I should be paying for Cologuard versus FIT or versus colonoscopy. But as a payer, do I want to incentivize physicians to find cancer or adenomas? Adenomas. So now look down here. So here we are, precancerous lesions. Look at those numbers. Look at these numbers. I'd have to pay $238,000 to find one non-advanced adenoma versus paying $100,000 or what is that, $16,000 for FIT. So as a payer, I looked at that and said, I don't want Intermountain Healthcare to find more cancers. I want them to find more non-advanced lesions and precancerous adenomas. So as a payer, we looked at this and said, we are going to pay, and then what I could do is, again, go to Julene Wadsworth on the 3rd floor of the other building and say, Julene, pull these CPT codes for me, tell me how many of these, multiply it by this number, and so on and so forth. We didn't pay for Cologuard. It's a super expensive way to find what colonoscopy does better at less money, and it finds more non-advanced adenomas. And then what I did, furthermore, is I took those numbers on that right side table and said how many of these patients, once Cologuard does find a non-advanced adenoma, we already had to pay whatever I said for Cologuard, $600, and then I still had to pay for the guy to have a colonoscopy. So, pharmacogenomics for psychiatric medications, we already talked about that. Number needed to treat is the mathematical reasoning behind companion diagnostics. If I know who the intervention will work on, then I want to do number needed to treat. Don't oversimplify it. It's simple, but it's not that simple. I'm going to skip this one. Awesome, awesome, awesome technology that not many payers pay for, and I still can't figure out why. I'm going to skip that. Don't care much about your clearance. As a payer, we don't really care about FDA clearance. It is a baseline, do you have it or do you not? At Intermountain Healthcare, we really didn't care. We paid for a ton of things that were not FDA cleared, that were off-label and so on, but there was great evidence for it. And we paid for things we shouldn't have paid for, like epidural steroid injections for disc pain. I want to give you this example. How many of you, don't raise your hand, how many of you, when you go to the car lot to buy a new car, actually believe the MPG number? I don't. I live in Utah at the base of a mountain. It's 4,800 feet altitude where I live. I have kids in a car seat and a briefcase and a dirty air filter, and I turn on the heat and I roll down the windows, and my tires aren't inflated like they should. So that's actually how they determine the MPG testing for a car. So very standardized, right? I could put a Hummer on there, I could put a Prius, or I could put whatever car. So it is a standard. You know, I'm going to put it on the rollers, and I'm going to blow a fan at 65 miles an hour on there and have a brand new perfect air filter. Now, go ahead and take that car out on the street, take it to 4,000 feet altitude where I live, where there's less oxygen for the air-fuel mixture, and the MPG is going to plummet. This is what most of you presented to me between 2010 and 2017 and said, Nick, I want you to pay for this. And I said, thank you, but where is your RWE, real-world evidence? You read about RWE everywhere. Where is your real-world evidence? I want to see that car on the road. I want to see that car driving. I want to see it with car seats and a dirty air filter and so on and so forth. That's what I want to see. I don't care about this. There are innumerable industries that are based around helping all of you. If you're like, I don't care about health economics, it has the word economics in it, I'm not interested, then go to one of these companies. Tons of companies out there that are designed to go, look, I know what Nick's talking about. What's your technology? I'll help you do the clinical trial you need. I know exactly what you got to get done. You write me a $150,000 check and go away, and I'll get it done for you. That's what these guys do. Payers pay for clinical utility, not clinical validity. If you only have clinical validity from animal trials and that type of thing, you haven't got far enough, and payers will say, come talk to me when you show some sort of healthcare improvement at an appropriate cost. Don't consume all the benefit you're providing me. You have the chance to take the hottest girl at school to prom, and she orders filet mignon. And you go, look, lady, I'm 16 years old. I can't afford filet mignon. Your best friend's kind of hot, and she would have had a Caesar salad. Right? I should have taken her. Right? You consumed all the benefit you're providing me. I had to pay $80 for your stupid steak. So this medical device companies do this all the time, and they charge so much money that I'm like, I can't. Again, number needed to treat type stuff. If I take the cost you're charging me and divide it across all these people, I'm going to go nowhere. And all I'm going to have to do is raise all of your monthly premiums another 82 cents next month. So don't consume all the benefit you're providing. Now, this is part 2 of this 3-hour lecture I'm trying to do in a half hour. What is insurance? I cannot believe I'm even hearing myself ask this. Such a dorky question. What is insurance? It is a risk adjustment for unforeseen events. Right? If it's not an unforeseen event, then if it is a foreseen event, insurance shouldn't pay for it. That's what your savings account's for. So on my car, I have a calendar. It's called an odometer. And when I went and I bought my new Michelin tires for my car, and they said, Nick, these are 50,000 mile tires. I go, great. I have 50,000 miles on my car. I'll be seeing you again at 100,000 miles because then I got to take the tires off. What would happen if Geico started paying for tires? Was getting new tires an unforeseen event? Was the oil change I need every 3,000 to 5,000 miles an unforeseen event? Was the windshield wiper fluid or the windshield wiper blades wearing out, was that an unforeseen event? No, it wasn't. You know you're going to run out of windshield wiper fluid. You know your tires need new tires on them every 50,000 miles and oil changes every 3,000. You knew that. So Geico says that ain't our problem. We pay for car accidents and all the unforeseen events. If you lived on the San Andreas Fault, you know, what would Allstate say to you when they'd be like, you know, this is not really an unforeseen event. Your house is going to crumble. You know, and so this is what happens when governments pay for you to live in flood zones. Government subsidized flood insurance. This is what happens during Hurricane Sandy and Katrina and all of this. It incentivizes you to take risks that you otherwise wouldn't do, save that somebody else is paying for it, right? Speaking like a true economist and libertarian. So what is insurance? It's a risk adjustment for unforeseen events. If it is foreseen, insurance should not pay for it. Now, here we go. This is where half of you are going to throw hard things at me. Is a prostate exam or mammogram an unforeseen event? No, you scheduled it. You booked it. Now, what most people do is they raise their hand, they say, no, but prostate cancer and breast cancer are unforeseen. Not if you get a prostate exam and not if you get a mammogram. So all the foreseen medical interventions that we have, colonoscopies, prostate exams, mostly diagnostic procedures, are foreseen. Now, when I get strep throat, maybe a different story, right? I didn't know I was going to get strep throat. So maybe that is something insurance should pay for. But all the foreseen things I should pay for. And if insurance companies said, we're not paying for those things anymore because you knew they were going to happen just like you knew your tires were going to wear out, then I would have to have a savings account. The cost would plummet. I wouldn't be paying $900 for a colonoscopy. I'd be paying $9 for a colonoscopy. It's an 8-minute procedure. I believe healthcare costs will continue to escalate as we have more interventions covered by insurance. The more we say, no, not for me, and we dump it off on some faceless insurance company, the more costs are going to go up. Tuition, student loans, right? I push it off on somebody else pays for it. I could talk about that one forever. Tires, I already talked about. $10 tonsil Tuesday. Okay, when my dad got his tonsils taken out, it was during World War II. My dad just turned 81 years old yesterday. All the young physicians were gone. It was all the old doctors that were still around. His mom and dad walked him down the street. He had tonsillitis. They paid Dr. Taylor $10 to remove his tonsils, mid-1940s. A physician that I know of in Utah did the same thing until the 1990s. It was $10. You come in, spray some lidocaine in there, lop them out, cut out the tonsils, throw them away, sew them up, and send the kid home. What did we, $3,500 when we had our sons done a few years ago? $3,500 for a tonsillectomy. You could watch 15 YouTube videos and be 80% efficient and proficient at a tonsillectomy, right? Like castration, right? When I lived in Indiana, I castrated a donkey and a cat in the same day. I'm not a veterinarian, and I did it. You shove a cat in a boot, you cut off its testicles. If I took it to somebody who charged insurance money for that, that'd be like a $5,000 castration. So tonsillectomy, right? Pharyngeal castration. So I believe we're in a healthcare bubble, but what's going to pop it? Digital health. I really believe digital health is going to pop much of the healthcare bubble we're in. Innovation. It is not going to be some act of legislation from Congress. It's not going to be some bureaucrat. It's just going to be the free market saying, look, I don't know what a CPT code is. As you said, I'm not an insider. I loved it. Like, the people who are going to disrupt this are 19-year-old computer engineers sleeping in their mom and dad's basement. They're like, I don't know what tonsillectomies are, or I don't know what tonsillitis is, but I'll figure out a way to just plug a thing into my phone and blow in it. Let me show you this really quickly. All innovation, this is kind of a Clayton Christensen type model, right? Low tech, low cost, high accessibility. Then it goes to high tech, high cost, low accessibility. And then it goes to high tech, low cost, high accessibility. Almost everything does. This low tech, low cost, this back here is the abacus 5,000 years ago. Low tech, low cost, high accessibility. You could make your own, just a piece of stick and put some rocks on it and slide it back and forth and do math. Anybody could get one. It was a slide rule. Then, over 5,000 years, the scale grew, and then we had the mainframe computer from IBM, right? Very high tech, very high cost, but very low accessibility. And now we have all of our phones can do incredible mathematics on them. And we have the TI-89 calculator, high tech, low cost, highly accessible. And everything has to go through the zit-faced teenager awkward stage where you're like, why are you horrible? And it's like, well, that's like growth. That's normal growth, and that's how things develop. I don't know why. So let me give you a few examples. Transportation did this. Low tech, low cost, highly accessible was a horse, to high tech, high cost, low accessibility, and now to the airports or drones. I mean, we're talking about flying ourselves around now. Low tech, high tech, low cost, high accessibility. Education, the old country school to the modern universities. Look at the zit-faced teenager stage modern universities are in. $50,000 for a bachelor's degree in French. Right? This like ridiculous, you have student loans and FAFSA, and you have faculty and adjunct faculty, all these terms and nomenclature that didn't exist in old country schools or old country universities. And now we have the Khan Academy. The poorest kid in the slums of Mumbai can learn differential calculus on a smartphone that some NGO gave him. People are going to start to say, why am I going to go to a modern university? I can just sit at my house and learn everything I need to know, absent a laboratory, right? So there's a few things, of course, that'll have to be worked out. Telecommunications, entertainment from the entertainer's perspective, computation, and medicine. Low tech, low cost, highly accessible doctor's visits to modern hospitals, which is high tech, high cost, low accessibility. I don't care how much insurance you have, you're not getting in a hospital. And look at the hospital. Let's just, again, go through the nomenclature. You have ICD-9, ICD-10, CPT, DRG, MD, MPH, DO, OD. We keep going all day. You have an RN who works for an MD. You know, that's like the more acronyms we have, the bigger this system gets. The more conflated. It's become so nauseating that we have to add all these acronyms to it. And then ultimately, where's medicine going to go? For diagnostics, it's going to go to digital health, where I'm just going to diagnose myself. I'm just going to blow in my smartphone or have a little chip that I urinate on and I plug it into my phone and I run my own prostate exam. Right there in the comfort of my own home. There's no reason why pap smears and those types of things can't be done at your own home with simple devices these days. And that's all coming, and I'll show you an example. Stethi, the founder, just spent a weekend at our house. He's from Brisbane, Australia, Nayar Hussain. He's a physician, got sneezed on by a little girl, and he said a big booger, like gross, landed on him, and he goes, as he was holding the stethoscope on her chest, and he goes, this thing, he said it was like an epiphany. He's a Muslim. I don't know if they have epiphanies. He put this on her chest, and he goes, what are we doing? Why am I holding this on your chest? I can't hear anything. I'm covered in snot. Like this is, he really like had this vision. And he said, what if we do this instead and put that little device that looks like a hockey puck with the blue thing on it over there? What if I just give that to you and you can go home and do your own 3-lead EKG at home? It's as good as a 3-lead EKG. Not as good as what your cardiologist would give you, but for my dad that's had 2 heart attacks, my dad would take that over what the current standard of care is, which is wait till you have a heart attack and then go to the hospital. This is using AI. It actually has predictive analytics to gauge when you will have a heart attack, and it's FDA cleared as of November, Class 2 510K. Visualytics is my friend Samir Trika. He's an eye surgeon, and he said, I have patients that come in and do a optical coherence tomography scan of their retina, and then I look at the image and say, yeah, you have diabetic macular edema. You have macular degeneration. And he goes, I do like 50 of these a day. And he goes, it hit me that I could probably just have a computer do this and train an algorithm to look at the fovea and tell me what kind of disease you have or if you don't have anything. And I talked to him and I said, Samir, when did you come up with this idea? Like, how long ago? And this was in April. And he goes, I approached my buddy about it after I had some thoughts about it in October. And between October and April, they developed the algorithm. By March, the Singapore Ministry of Health goes, yeah, this is great. We don't have enough ophthalmologists to view all the OCTs that we need to view in a day. Your AI can do it, and it's 4% more sensitive than the best ophthalmologists. 4% more better diagnostic accuracy. So he goes, I essentially just kind of put half of my income out of business. So he's like, I'm fine with it because I own the company. So Apollo DX, this is my friend Jason Young. He's a physician, and said, you know, there's so many of the tests that we do that you could just do yourself. You don't need to come see a doctor to do this. You can spit in it, urinate in it, whatever, and you put the little dipstick right here. Dip this into that and plug it in here, and then run the test. They're already full-fledged in India. Rural clinics are using it there. BioMeme to do RT-PCR, NanoSynth, and so on. Infrastructures are being built for this stuff. It's already happening. And furthermore, can I back up? Please don't try to get reimbursed for this stuff. That's the point. The point is that you're getting away from the top of that bell curve and you're inventing digital health, saying, I'm done with insurance companies, I am done with physicians, I am done with hospitals, I am done with all of that. I'm gonna go straight to the consumer, and when you have a sore throat, you're gonna go to Walmart, aisle 9 on the right, and you're gonna pick up a little box of these things, and you're gonna spit on it or swab your throat, plug it in your phone, and hit scan, and then it'll say, yeah, you sure enough have a bacterial disease. Would you like Amazon to bring you your amoxicillin? You say, yes. And then you stay at home, and you don't infect the rest of us. Like, none of that is ridiculous. Like, nothing I just said is ridiculous in the day and age we live in. Please don't leave your home. Cough on this thing, urinate on it, whatever you do, plug it in and run the scan. And my argument for, how do we help get innovation to, developing nations and things? This is how we do it. You and I that have a lot of money spend that money on these new innovations. It decreases the price, and these eventually go overseas. And now again, starving kids in rural villages in some other country end up getting infinitely better health care than we currently have, and they'll have it in a few years. It'll get there. And we'll be dropping little boxes of these diagnostic things into villages everywhere. One guy with a smartphone. By the way, there's more smartphones in Africa than in the United States. More smartphones in Africa than in the United States of America. 300% increase in smartphone purchase in the last 36 months. So Africa has the infrastructure for this stuff. And if they don't right now, if certain places don't, they will. And the kids aren't gonna have to all line up to see one doctor. We're just gonna make all of you doctors. All of you are gonna do it. And you're like, I don't know where my heart is, but Steffi is telling me to put this somewhere. And it will tell you, no, down to left, 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 stop, push down the button. That's where your heart is, remember next time. And it will put it in your thing, and it will send it off to some AI that will come back and say, you have mitral valve regurgitation, you're gonna wanna see a doctor ASAP. And now you're gonna see the doctor. Now you're gonna have an intervention. That's it. Thank you.